Okay, well, welcome everybody to the ATI seminar series. I'm Kieran Halloran. I'm a lung transplant respirologist at the U of A, and I'll be moderating the session today. So today we're fortunate to have Dr. Shojai here from Transplant Nephrology to be presenting to us. I'll just start with a land acknowledgement. The University of Alberta acknowledges we are located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada. I'd also like to thank Paladin for their ongoing support of the ATI seminar series. So I'll just give you a brief introduction of Dr. Shojai. He's an associate professor in the Department of Medicine here and a transplant nephrologist at the U of A. He received his MD from Shahid Beheshti University in Tehran, Iran, and he's completed his postgraduate training in internal medicine and nephrology in England, where he was appointed as a nephrology consultant, and then he completed an ASN-approved kidney transplant fellowship at the University of Alberta prior to his current appointment. So now he's a clinician investigator, and his interests are in improving patient safety, quality improvement, health outcomes, optimizing the utility of DCD kidneys, and recognizing and reducing barriers to living donation and living donor kidney transplantation. He's been a principal investigator and co-investigator on various grants, including the current Prius grant from Alberta Innovates. And he'll be talking to us today about multidisciplinary support to access living donor kidney transplant, the MuST AKT trial, which is a pilot randomized controlled trial. So Soroush, I'll hand it over to you to take it away. Great.
Okay, perfect. Thank you very much, Kieran, for your kind introduction. And thanks to ATI team to give me the opportunity to share what we went through with our colleagues here. So the purpose of my presentation today, of course, I don't have any conflict of interest, and luckily I'm not advertising for any drugs today. My objective for this presentation was mainly sharing our journey with you. You know, in the kidney transplant, like many other programs, we have our some unique challenges. We also have some sort of universal challenges. So I'm hoping by sharing our journey with you guys, we can you know, come to a common ground and shared understanding of the challenges which we're all facing, and perhaps trying to find the shared solutions which would help across the programs. So the first part of the presentation is a very quick review of current evidence behind the interventions we can do to increase the living kidney transplantation, and to understand the current status of our projects, and to understand the rationale why we use what we used, and appreciate the complexity and challenges of complex interventions, which we believe what we are doing is a complex intervention. So let's start with why we are doing what we are doing. So if you compare the outcome of kidney transplantation versus the dialysis, those are the two main interventions or choices for our patients if they want an active treatment. Of course, there's always a palliation and conservative kidney care, but active treatments, two choices: dialysis, PD or HD, versus transplant. Transplant, living donor versus deceased donor. And this, you know, green line here is showing you the outcome, the 10 years outcome for kidney transplant recipients in Canada. So this is our data versus the outcome, 10 years outcome of dialysis group. And this is unadjusted survival. So some can argue, you know, perhaps some of these dialysis patients are not even a candidate for a kidney transplantation. So maybe the people who are on wait list and are actually a candidate have a better prognosis, which is absolutely true. But, you know, we are talking about, you know, 10 to 20% or 15%, 18% outcome, let's make it double, say, okay, maybe it's not 20, maybe it's 40. Then we are comparing 40 to 80. So truly, living kidney transplantation can double a recipient's lifespan. And I think, you know, that's accepted fact in our subspecialty at least. So that's survival benefit. No, you know, controversy there. What about the healthcare and taxpayers' money and healthcare affordability? If you compare the dialysis cost versus transplant cost, roughly the first year after transplant, because we have surgery, admissions, all those expensive medications and interventions at the beginning, is more or less the same. You can say, you know, the PD has a little bit lower, the HD a little bit higher. So maybe we can say the first year is equal. But certainly after the first year, especially now we have generic medications, the cost for the kidney transplant patients, the cost of their healthcare would be much, much, much lower than dialysis patients. So if the same patient stays on dialysis, it still has an $87,000, $80,000 per year cost of dialysis versus $20,000. So this is a win-win because, you know, we hardly have an intervention in medicine which has the best outcome for the patients. It also is cheaper to provide it. You know, you can argue maybe vaccines like a prevention measures are similar. I agree with that. But, you know, the active treatment measures we have, we do so many expensive interventions with actually a lot of cost to our healthcare, and the argument is there actually. Is it worth it? Are we able, you know, perhaps using the better word is not, is it worth it? Are we able to afford this intervention? Because even a second increase in the life of a patient, if the patient's choice is increasing his or her life, worth everything. But you know, are we able to afford it? So that's the win-win for us. And of course, there are lots of evidence for better quality of life on dialysis. So even when we transplant an elderly person who cannot, you know, gain that much of years to his life or her life, still have much better quality of life with transplant compared with staying on dialysis. So that's why we are doing what we are doing. And to help people get transplants, so I hope I convince you transplant is the best option for them. So let's transplant everyone. And of course we can't, because the organs supply is limited, as we all know, and the wait list is increasing. So we have more and more people on our wait list every year. And despite very good activities, transplanting as many as we cannot catch up. So perhaps the main way to increase our donor organs in the kidney transplant is by going down the route of increasing the living donor kidney transplantation. So you can technically say we have way more than demand supply pool, because there are so many healthy people or super healthy people in the community who can technically be a kidney donor. So we started thinking about the problems we have and started thinking about the duty we have to our patients. And that happened to be at the same time Alberta has started an initiative, strategic clinical networks, and one of the first ones was in kidney health. So that was a very fortunate time for us, and luckily kidney transplantation was one of the priorities for Kidney Health SCN. So we had the cooperation and help of our colleagues in administration and AHS, which was great. So one major barrier down, and they found that as a priority. That's a second major barrier. So we saw that opportunity. We thought, okay, great, we should do whatever we can for our patients now. And then from the very beginning, we were cognizant we should do this in a scientific way. And the main reason for that was our experience with other QIs. So, you know, in the QIs, there are so many good ideas and people start doing all the good things at the same time. And at the end, when you look back, it's very, very difficult to separate and say, okay, which part of this is really driving this benefit, if there is a benefit, and which part is not really helping that much. So if you want to choose what's the main part we should choose and keep. So we were cognizant of that and wanted to do it in the right way. So we opted the knowledge to action framework, which is established framework in CIHR, to do what we wanted to do. And we went through this cycle few times, and so far, and we're going through the same cycle again and again and again until the end of a project. And then hopefully we will change this cycle to a CQI, continuous QI cycle, after the project is hopefully successfully done. So the first thing we did was a presentation in Leduc. I call it Leduc Summit. So the SCN brought all stakeholders, patients, multidisciplinary team, surgeons, physicians, everybody at one table in Leduc. And we also did a survey of the same group, like before that Leduc Summit. So we surveyed the patients and multidisciplinary team and administrative team about the living kidney donation and kidney transplantation and the barriers they think they're facing or patients are facing. And we presented that in that summit. And the result of that was development of living donor kidney group as part of the umbrella of KHSCN. So the first thing we found out was, number one, we need a reporting system, data gathering system, which we're lacking. You need also to remember that we are in one province, but we have completely two separate systems, or we had at least at the time, completely two separate systems, you know, north and south, or Calgary versus Edmonton. So the first thing was bringing everybody at the table, agreeing on a common grants, and starting to standardize the standard of care, if you like. So at the time, you know, the Calgary team were doing great things, but in their own way. Even the teaching materials they were using for the recipient or donors, or the way they were presenting them, they were all different from what we were doing in Edmonton. So the first thing we did was standardizing the standard of care. So we developed a new sort of teaching materials for our patients, which was accepted by both teams, used by both teams. We talked about the accessibility. So it's not just when the patient's coming to unit or to the session, having access to those things. You know, traditionally we were just printing a bunch of papers and giving them to them. So we changed that. We put all these materials on My Health Alberta website, which is the standard patient education resource in Alberta, and is 24/7 available, accessible. And the good thing behind the scene was we also set up a system to gather the data from the website. It's anonymous data. We don't know who is accessing it, but we do know how many people are accessing them, and which part they go to, and how many seconds they spend on the website. So that's a very valuable information to guide us. And you know, it's very interesting to see this variability by the seasons or by events. You know, when there was a sad events, in another province, and we had those young people tragedy who died, and some of them donated their organs. There was, increase in the activity in our website as well. So it's very interesting monitoring there. The next thing was, okay, let's review the current evidence. So Dr. Klarenbach and his team basically did a scoping review. And that was very sort of clever way of doing it, because as you know, the scoping review is I look at it like a very efficient way of getting what you need in a very quick way. And if you do it properly, it's a very good possibility you will get really what you need. Of course, it's not the most comprehensive way of doing this. A meta-analysis and systematic review would be much more comprehensive and established way, but I think this is a quick one. So we did that, and the conclusion of that was, despite so many good attempts and good intents, people did very important things which made sense. If we bring people together, patients together, if we go to the dialysis units, if we change the materials we are giving them in a way they can understand it better, all those things which make sense, that should increase the living kidney donation. But actually, when they were put in the proper examination setting, in a randomized clinical trial, for example, number one, there weren't many of those. Number two, there weren't many who were conducted properly with acceptable amount of bias. Everything we do has bias, but acceptable amount of bias. So we ended up basically with this conclusion, and was strategies directed at potential recipients, and their social networks are the most promising strategies. And technically, we are talking about one particular strategy, which was home education. So in Netherlands, in US, in a couple of centers, people send social worker or educators to recipients' home, and basically they started talking about living kidney donation and transplantation at their home when their family and friends are invited to the session. And looks like the only, effective intervention in a randomized clinical trial was that intervention. Later on, that was 2017, the scoping review. Later on, when we started our project, starting preparing for the changes. And then later in 2019, our colleagues in Montreal, they did a proper systematic review and meta-analysis. Their conclusion was educational interventions improve measures of a living donor kidney transplantation. So let's dive a little bit deep, see what they meant with that measures of living kidney donor transplantation. So number one, so many of the interventions, including those interventions I called home education, they were done in a different setting. And for example, in American setting, there is a gap between the general nephrology team and the transplant team. And basically, one of the major barriers in that setting is referral for kidney transplantation. We hardly have that problem. We might have some process problem, like, we started the assessment for kidney transplant evaluation in the recipient, and the things are not done properly or in time, and we're having difficulty gathering those data, which part of evaluation is done, to make sure everything is done and ticked, and then refer to the You might have those logistics issues, but we hardly have that issue of, is there a systematic bias referring patients for transplant? One of the reasons is, we are so sort of one team here, especially in Alberta and in other parts as well, even when we have two separate teams, kidney transplant versus general nephrology, they are working together, and the problem is not a referral really, or convincing patients to go for transplant. The problem is actually finding a living donor for them. So that first part of LKD evaluation has been a major outcome for so many of these interventions. So after their intervention, there were more people referred for kidney transplantation. Sure. So that's not really our problem. So some of the other outcomes they choose was a living donor contacted a living donor services to start or inquire about living kidney donation. And some of those just counted the number of contacts. Some of the studies actually counted the number of contacts for a specific recipient, because those are two different things. Randomly I'm calling there versus I'm calling particularly to see if I can donate to a loved one. So that was another outcome of some of these studies. And the last outcome, which is the hard outcome, not a sort of a soft outcome, would be actual increase in kidney transplantation. And this more comprehensive study also showed that, if you look at the contact and inquiry, apart from this one study and the other one here, which are actually those, three part of the three studies I mentioned earlier, home education, everything else, confidence interval is passing the line 1. So that means statistically there was no difference in whatever intervention they did. And if you look at this for hard outcome of kidney transplantation, this one is Rodriguez study is just touching the line, and the overall study is touching the line, and almost no other study is showing a clear-cut benefit. There are some hints towards some benefit, but not a clear-cut benefit. And some of these studies have a small number of patients, so the argument might be, maybe it's not powered appropriately to show the difference, which can be true. So this is where we are, or where we are with our evidence. So what we decided to do was coming up with a tailored education to increase living kidney donation. And based on those studies I showed you, in at least one of them, the living kidney donation increased with that home intervention by 34%. And what I believed, to be honest, from the very beginning was, especially after we standardized our education across the province, I didn't really think our patients' problem is lack of education material. Don't get me wrong, we can always improve our education material. But what was lacking was an action, was a behavior. And that needs education material, certainly. But education is not limited to that. And I think we were honestly saturated with those type of materials, especially if you just search in a Google any subjects about living kidney donation or kidney transplantation, you are bombarded with so many materials, and some of them are very, very reliable materials from other very famous centers in the world. So I don't think people have lack of access to those materials or have problem finding those teaching materials or facts. It was a behavior problem. So basically what we found out was, based on the evidence, a targeted potential recipient and their social network, that was the friends and family home intervention, is important part of this intervention. It should be culturally and contextually tailored to our patients. So we can bring something from Europe or from America to our patients here. Even you can argue maybe our patients in Alberta or Saskatchewan are a little bit different from Ontario, or maybe a bit different from BC. So context is important. That should be individualized. One size fits all doesn't work. You can't just say generic things to the patients. You should listen to them and find out what's the specific barrier and try to address them. And then we should design this intervention in a way that we are not giving them the information, we are actually enabling them to do what they need to do. That idea resonated with everyone, resonated with patients, resonated with other stakeholders, with administrations. So we brought patients, we already had that sort of foundation there from the Kidney Health SCN. You know, the patients were actively involved in all these designs and decision-making process. So the three pillars of our intervention, patients, family, healthcare providers, and operations were there. So we tried to consider their interest separately and collectively. And then we tried to choose a framework. So the framework was important for us, and we recognized from the previous experiences we had, you know, embarking on a complex study or intervention without doing a pilot or feasibility study would be a big mistake. And I can tell you honestly, as we went through this, and we're still going through this, every few weeks, I think about that lesson, and I see how important was doing that pilot or feasibility trial. So the most recent guideline published in 2021 from MRC UK is basically our framework for feasibility studies and complex interventions. And we try to follow that framework for people who want to do a complex intervention and they already haven't used it. I strongly suggest to have a look at it. It's a very comprehensive and good tool. There are some sort of terminologies or adapted definitions for pilot study. I don't want to get into the nitty-gritty of pilot versus feasibility studies, but you know, there are two separate things we need to do. You know, in a way, the most accepted definition is, you know, your pilot study is mimicking your definitive study or intervention. So you are trying to do a miniature sort of a scale of the same big one you're planning to do later. And the feasibility studies might not have exactly the same components, but has its own components which are trying to basically find out the barriers and the solutions to those barriers to do what you are planning to do in your definitive studies. So that's my understanding from these two sort of terminology. And there are again published guidelines on those things which we can follow. So we also realize we are going to deal with the behavior. So we studied various behavior change frameworks. And one of the acceptable ones, especially in the social behavior and healthcare behavior, is this COM-B model. So a COM-B model is a behavior system. The components are capability, opportunity, and motivation. And basically, the COM-B is telling us for a behavior to happen, you need to have three components, or patients or whoever is doing the behavior needs to have those three components, should be capable of doing that, should be motivated to do that, and also should have an opportunity to do that. So, you know, if we are not giving appropriate information to our patients, if we are not helping them, enabling them to be able to do what we are asking them to do, for example, share your needs with your friends and family to find a living donor, then they are not capable to do that. We should not expect the behavior. If we are not, if they're not motivated because of so many barriers they have, for example, they are frightened, or they believe they won't be able to find anyone. So if the motivation is not there, the behavior would not be there. And then if they don't have opportunity, they want to share this with other people, but they don't know how to share it. They don't have any means to share it. So they won't be able to do the behavior. So the COMBI model was our behavior change framework. And this is a little bit more complex than just that 3 components, and it has different layers. It has those 3 components as a core, and then based on each component, you have another layer on it, which is your intervention functions, and then each intervention functions has a source of behavior. And if you go out, when those functions are in situ, then you need to have a policy, or if you want, you need to have appropriate guidelines, you need to have appropriate measures, or you need to have appropriate service available for those behaviors to happen and to be sustained. So what is the MuST AKT pilot? The MuST AKT pilot study, we decided to limit our study with putting some sort of inclusion criteria, for example, selecting just English-speaking people. The reason for that was we weren't sure even this is the right thing to do, and we didn't really have resources to, for example, translate our materials to various languages. So it was like a feasibility or accessibility, if you like. We chosen to go that way. Of course, if the intervention is effective and in English language people, then we will expand that, and that would be in horizon. We went with adults, and we tried to include everybody who is sort of a potentially candidate for living kidney transplantation, and they should not have any obvious contraindication to kidney transplant, and they should have completed the introduction to kidney transplant teaching module. So that was our sort of standard of care. So everybody was going through that basic standard of care of teaching. And then we had some exclusion criteria. For example, multi-organ, people who are waiting for a multi-organ, we excluded them. People who previously had a kidney transplant or a transplant, we excluded them. So there were some exclusion criteria. And then we wanted to make sure we are doing this intervention in the right group. In our standard of care, currently we have SIPAT scoring, and social workers go through that assessment. So we use the same sort of assessment to make sure there is no sort of severe depression or that type of barriers to this, because those needs to be addressed first. And that's more or less this across the board as a standard of care. And we also wanted to make sure we have some sort of a objective measurement of people English language literacy and medical literacy. So we use ROM 66, which is established standard assessment for patients' literacy. So those were our exclusion criteria. And then we recognized that there is a research practice gap. So it's not just doing a great research and come up with a great randomized clinical trial outcome. We need to be able to use them in the real life, in the field, if you like. So the facts are, it takes 70 years for research to reach practice, and only 14% of research reaches a target recipient. So we think this research is good for this particular recipient, but we can't really reach them. and only 18% of administrators and practitioners report using the evidence-based practice frequently. So the evidence are there, but they are in libraries, they are in laptops and computers and internet, they are not really in the practice. So that was a gap we recognized early on. So how can we close that gap? That brought us to REAIM. So basically, REAIM is a framework. So basically, trying to close that gap for us. So RCCs are very carefully designed, executed, monitored with a lot of emphasis of internal validity, usually applicable to a very, very narrow people, well-defined targets, and that's the nature of RCTs. You can think about, like, you know, what we are doing in a lab versus what we are doing in a real world and field or bedside. And if you, for example, take pertussis vaccine as an example, efficacy of the vaccine after initial childhood vaccination was more than 85%. So it's a very, very efficient, efficacy is hard, efficient intervention. After booster, 92% of kids would be sort of immune against pertussis. But what's the vaccination rate? 25%. So evidence is there, field, something else is happening in the field. So there recent years been lots of questions raised regarding the necessity of evaluating other factors associated with these interventions. And the implementation science has reached a lot of sort of attention. So robustness or transferability of the interventions and the public health impact are the major pillars of assessing effectiveness of the intervention in the field. And we use the REAIM framework to help us in that implementation part. And the implementation part for us has two components or two settings. One implementation is we are trying to implement the evidence we have, the evidence-based intervention we have in our services. That's one thing. And then we want to make it a standard of care across the province. So that's another implementation. And we use the same framework more or less for both, with some modifications. So the outcome measures are basically divided in few groups: patients, providers, process, and program outcomes. We use the expanded consort framework as our framework for outcome measures and reporting. So clinical effectiveness, reach and recruitment, acceptability, appropriateness, PREMS, and session effectiveness in that consort expanded framework. And in implementation part framework, if you like, we use REAIM for research, reach, for effectiveness, for adaptation, adoption, and implementation and maintenance, which is another important part. Many good interventions happen, but they don't sustain. So maintenance is another part. So here are some of the examples of outcomes. For example, we considered some feasibility and fidelity outcomes, like a consent rate, recruitment, withdrawal of a consent, or for each session component, how many of those session components or intervention were actually completed. So completion rate was one outcome. And we developed some logs for that. And then acceptability and PREMS were another outcome. Efficacy outcomes were also important. Number of potential donors for advocates, for example, identified during the session one, and proportion of recipients with at least one potential donor who started evaluation. We measured that. So those are some examples of outcomes. So what is our project sort of framework and timeline framework for us? So we started preparation in 2020. And before that, we actually had a hidden part. All those efforts done through the SCN was between 2015 and 20. And actually, we were so grateful to the K Foundation because our pilot study was funded with K Foundation grant, which was great. So we started preparation for that. The pilot study started in 2021, and we're still getting some outcomes. I tell you why. And then definitive RCT, we just started recruitment for the definitive RCT, and that's going to go ahead in 2023 and 2024. And then we will start the implementation phase 3 of our intervention in 2023 and going to 2024. And this intervention was basically supported by a grant, just shy of $1 million grant from Alberta Innovates. Our intervention have 4 pillars. So we have 4 major sessions, session 1, session 2, 3, and 4. And in session 1, we are trying to identify the potential donor and advocates. Session 2, we help the patients write their story. And the next part in the session 1 would be social and financial, finding out about the social and financial barriers they have. And then we will use those components in the other sessions. For example, session 2 is trying to enable them to have an effective conversation. And the conversation is actually a limited word for that. It's actually communication. They can use their own methods of communication, and we just try to enable them to have an effective way of doing that. And then the advocates, potential advocates, we find in the session 1, we enable them to utilize those advocates. And then in session 3 is trying to share the story they wrote in session 1 with other people and enable them again to do that. And then session 4 was equivalent to that home intervention. When we started planning for this, one of the main headaches I had was how on earth I can convince the ethics to approve, for example, WhatsApp or some sort of a social communication methods or online methods of communication with the patients to discuss their medical health issues. And it was a major concern for me. We're not going to get the ethics approval for that. And then, of course, COVID hit. And one of the good things, if we can say anything good can come out of the disaster, was, Zoom became a standard way of practice and easily acceptable. So we were lucky in that way. That barrier we had went away quickly. So we managed to get the patients, give them an opportunity to use the Zoom, for example, for our intervention. We're still giving them the choice for any in-person. Of course, there were limitations during the COVID pandemic time, but now the pandemic is sort of less of an issue. The patient have a choice to come in person as well. So we did our enrollment, and in the next couple of minutes, I'm going to share what we learned from the enrollment and so far from the pilot study. So the enrollment was basically from 2 sources: our wait list in the pilot study and the teaching class. Everybody is coming to that virtual teaching class as a standard of care. And they will be basically approaching that teaching class by, after hearing about the study, by the care provider. And if they're happy, they will agree to give their contacts to the research group. So that's the consent to contact, if you like. And then we will contact them and go through the details of the study and basically the process of asking for their consent to participate in the study. So that initial enrollment was basically the first part, which was before the study group having the permission even to contact the patients. And the total number we had in a wait list, we went for like 13 people, and then based on exclusion inclusion criteria, a few were excluded, for example, and then we ended up with 7. And in the transplant teaching class, 204 people were pre-screened. Basically, they attended the teaching class, and healthcare providers told us, for example, they previously, some of them, they previously had transplant, or they were just for teaching class only. They were not deemed appropriate for kidney transplant, or they sort of had already a donor in assessment. So that those were initial exclusion criteria before the consent, and they sort of excluded those for us, and we left with 116 people to be approached potentially. And then out of those, 50 did not consent to be contacted. So they didn't ask, they didn't want us to contact them. So they were sort of out, and then we left with 63 who consented to be contacted. So imagine 204 were there. The argument is they weren't all sort of target population for us because of those obvious criteria, but 116 potentially could say, yes, we are interested to be contacted, at least hear about the research study. But out of those, only 66 said yes. So that's a lesson, is a generic lesson. And I think even this is a very good number of consent to contact. In other trials, some of our colleagues are doing, and I was tangentially involved, that rate is way, way lower. So people, at least in our world, they're not consenting to even be contacted for listening about the study. And that's so different from what's happening in, for example, oncology or cardiology. So that's something we should learn from them. And then the next part was our inclusion-exclusion criteria, and after the discussion, seeking the consent from those people, and we ended up with 38 people to be randomized. And then our consent, after we contacted them, our consent rate was sort of around the consent to be contacted. Before we contact was 35%, that's 66 from 116. Our consent rate was the other way around, was 61%. So when they actually listened to what we want to do, 61% said yes, which I think is a great consent rate. And then we tried to find out what was the reason for decline. So 7% preferred not to tell us, and some people were unable to be contacted. That was another major barrier. And some were too busy. Life and healthcare issues are super busy for them. They don't have time, understandably. And then some wanted even to be cleared first as a recipient, then consider the study.
So just a heads up, we're at the 10-minute mark.
Sure. And then we have unable to contact 15 people and the reasons for those. So participant recruitment timeline was over roughly 8 months. From May we started to January, and randomization, 38% randomized in 2 groups, and in the intervention group we had like 1 person who didn't receive the intervention because already find a living donor before even we start the intervention. And there are a few others, like, there was 1 person we couldn't contact afterwards and lost the contact basically. So overall, we ended up with 10 fully completing the intervention. And we also had a component of qualitative study, which we did. So basically, we approach everybody after the intervention to gather that trends and qualitative sort of outcomes from them. The session completion rate was different based on the sessions. The completion rate was roughly 100% for session 1, and as we went through the sessions, that dropped understandably, as we had some people going out of the study, for example. But we have like 60% session 4 completed, and activities in each session was completed successfully apart from session 2. And that was a lesson we learned from the pilot, and we, as a result of that, we changed and moved these components in the different sessions. We also had a qualitative study, which we got the report, and this is like a 55% versus 45% male to female, which is sort of the real life. And we also had some friends and family involved in that qualitative. These are some of the comments we got from the people. 100% recommended our program, for example. And the other comment we got from the qualitative study was they thought they got more information from the MuST Act than any other encounters they have previously regarding their kidney disease. They thought, the friends and families were interviewed separately. They also have very positive views on the MuST Act intervention. Participant recommendation was recording the sessions, which we already planned to do in the final study. They wanted more visual materials. They wanted more focus on advocacy, which we adjusted our intervention accordingly. More sessions they wanted, which is very difficult to provide. And they also want more resources for friends and family, which we already prepared to provide to them. And they also asked for another session. So these were like what we learned from our pilot. The outcomes, other feasibility outcomes of a pilot are coming out. So I don't have those yet to sort of share with you beyond what I showed you. And these are some of the people, the most famous ones who actually help us and supported us. And Alberta Transplant Institute, of course, is there as well. I apologize if I miss anyone. And I finish my presentation by saying thank you to you for giving me the opportunity, and I'm prepared for any comments or questions. Thank you.
That's great. Thanks very much, Soroush, for a really impressive overview of what seems to have been years and years of work, of immense work. Just because we're a little bit short on time, I'll just make sure we're getting all the questions in the comments section. Linda Powell asked, are you aware of similar initiatives for living liver donation?
That's a great question. I have not seen anything. Certainly, I haven't seen anything published. I sort of been trying to go to that clinicaltrial.gov and see what's going on there. I haven't seen anything there yet, but I think somebody just commented. I don't know if our colleagues are planning to do something in that regard, or CDRT part.
I think it was just Patricia posting that there's a CAHR funded consortium to support clinical trials. And so, it was an immense amount of work, and as you say, this has been in the works for years. And then there's a lot of attrition when you're speaking to people, and when you eventually get down to your cohort of 38 people. So is that a generalizable trait of educational interventions like this, of sort of educational behavioral interventions, that there's a high attrition rate, maybe because of the perceived time required or perceptions on behalf of the patients, or were you caught off guard by the attrition rate when you were enrolling people?
So that's a great question. There are two components into that. I showed you when the MRPs, the team are looking after the patients, approached them and said, hey guys, we really want to know how best to provide the service to you. And we don't know. And the only way we can find out is doing some studies, some research. Are you guys happy to hear about that? You see, 60%, they didn't even consented to hear about it. So that is across our specialty. As I said, that's different in oncology, that's different in cardiology. And they have so many publications on that. And I think perhaps that's the way they approach this problem. They don't let anybody have access to a new medications, for example, out of that clinical trial setting, which is appropriate to do. But the second part was when we approached them, 60% said, yeah, we are happy to participate. And I don't think really that 60% consent rate in that stage is a low consent rate, but you are absolutely right. If, for example, somebody is dying or losing the kidney and you are saying, I have a pill you can try that might be helpful, are you happy to participate? That's way different from, I want you to change your behavior. That's number one. What's wrong with my behavior? Number two, this is a 3 months intervention you need to do. And you need to spend like 1.5 hours per session. And we are going to send some materials to you to do at home. So you're absolutely right. There is a different perceptions of the commitment, if you like, based on your intervention. So it's not easy to do behavioral interventions.
And this is, and please, anybody else raise your hand or feel free to comment. I don't mean to dominate the discussion, but is this, there's been so much work you've done to get this up and running, to finally actually have the machinery working. Does this create the groundwork and the is there any potential infrastructure that has been developed for this that can then be used for other behavioral or educational interventions in solid organ transplantation here that can be leveraged for other interventions? Absolutely,
that's a spot on. So number one is not me, honestly. There's been lots of people behind the scene and so many people with me, helping me and actually running this. Annie, Terry, and Aman and my co-PIs, Dr. Klarenbach and Pastor Dawoodi, and so many people in SCN. We had the help of everybody, administrative people, programs, coordinators, everybody, they all shared the goal with us and helped us, and they are still helping. But I think we established some framework, and those are generic frameworks. Everybody can use the COMBI, everybody can use the K2A. Relevant in nephrology transplant, easy to copy from us. Even if it's the kidney liver transplant, you can transfer those to the liver. And I think we have that framework, and that was one of the aims we had. We wanted to have something which we can transfer that to other settings.
That's great. All right, well, if there are no further comments, I'd just like everybody to join me in thanking Dr. Shojai for a wonderful overview of all this work, and excited to see maybe in a follow-up session, the further analyses. And thanks very much, everybody, for joining us, and look forward to seeing you next week.
Thank you.
Thank you so much.